Good morning, everyone. My topic of today's presentation is navigating through OCT biomarkers in posterior uveitis retrospective study. The inflammatory process of uveitis causes structural and functional modification which can be studied by OCT. The primary objective of our study is to study vitreous, retinal and choroidal changes, predominantly in posterior uveitis, that is retinitis, toxo, CMV and Dosen cases. And the secondary objective is its diagnostic and prognostic implication at the molecular level reviewed through previous review of literature. This is a retrospective study of 50 patients, 30 toxoplasma, 11 Dosen and 9 CMV retinitis, studied in a tertiary eye care hospital at Kerala from Jan 2020 to December 2023. Predominantly retinitis was studied with a definite etiological diagnosis based on typical clinical findings, and the STOCT was studied. The cases with medial opacity, pure choroiditis, vasculitis or intermediate uveitis, and doubtful etiological diagnosis were excluded. A written consent was taken and EMR and OCT was studied, especially in active and healed cases with a mean duration of 3.4 months were separately analyzed and studied with the SPSS software. The mean age of presentation was 43.4 years and there was no sex predilection. Coming to the etiological diagnosis, toxo was 60%, which were 30 patients, Dosen 22, and CMV retinitis 9 patients, comprising of 18%. The best corrected visual acuity improved from 6/60 to 6/24, which was statistically significant. In toxoplasma active cases, the posterior hyaloid thickening, loss of demarcation between vitreous and retina, full thickness retinal thickening with back shadowing, which was disproportionate to the retinitis, and hyperreflective of posterior hyaloid, ILM and retina had the most positive predictive values. These are some illustrative cases. In this we can see a full thickness retinitis with no distinct demarcation line between vitreous and retina, and the inner retina had 100% hyperreflectivity obscuring the underlying structures, and adjacent thickened posterior hyaloid with vitreous condensation. There was blockage of outer retina disproportionate to the amount of retinitis and vitreous echoes. In toxoplasma healed cases, hyperplasia of RPE than RP atrophy with retinal thinning was seen, which had a high positive predictive value and which causes a finding similar to the focal choroidal excavation. Coming to a discussion, active vitreous in toxoplasma cases, we can see vitreous attachment uniformly seen in all cases at the site of retinitis, and the retina in between the lesions were normal. This suggests that the vitreous could be a culprit in the transmission of the tachyzoid. The role of ICAM1 in transmission of toxoplasma has been previously studied in dendritic cells and also in jejunum in vivo study. We suggest that the ICAM can also be a culprit in the transmission of tachyzoids through the vitreous. And in scarred cases, there is a resistance to RPE, which causes RP hyperplasia. The differential distribution of IF1 and gamma, TNF, IFN gamma and TNF alpha has been previously described in studies, which can cause the resistance of RPE to the tachyzoids. This is the RP and this is the retinal Muller cells. The RP is more resistant to tachyzoids. So highly suggestive features are dense vitritis, full thickness involvement with shadowing, disruption of vitreoretinal interface, full thickness atrophy and RP hyperplasia are the highly suggestive findings in toxo, and others are probable findings. In CMV, our cases were more of full thickness involvement than in cavernous type. RP hyperplasia was seen and there was little vitreous involvement. This is a full thickness case, and this is another case of CMV retinitis with vertical stripes in outer nuclear layer. So in healing cases, we could see there was thinning of retina with a resistant or ILM, and there was a substance of retinal layers involving full thickness. And this can be described as a substance and previously described in other pathologies like CNVM, etc. And this is already previously explained in other terminologies in previous studies in CMV retinitis. So highly suggestive features are full thickness retinitis with RP hyperreflective, ILM separation with thinning. In Dosen, active lesion causes full thickness involvement. But in substance science in Dosen is different from CMV. It's that there is outer retinal atrophy than a full thickness atrophy in Dosen as compared to CMV. This is already explained by Gaius, as Dusen mainly involves a local toxic effect on outer retina, which can explain our findings. So limitations of our study is a retrospective study, and no ocular fluid analysis was done. So we conclude that OCT act as a nearest to describe the microscopic involvement in posterior uveitis, that is retinitis, and standardization of these findings should be done in typical cases, which can be extrapolated to the atypical cases. Thank you.
The question will arise that what is the utility of this study?
Sir, as we know...
I know you want to say that we'll extrapolate it to atypical cases, but see, it's a straightforward diagnosis.
Yes, sir.
It's a naked eye diagnosis most of the time. Yes, we can use OCT in these cases, but because of the backscattering, you cannot really analyze the RP and choroid in most of the active cases. So we are talking here only about the inner retinal signs predominantly. So what do you see is the future of your results?
Sir, one thing is that as we see that most of these, as you have told, the retinitis is, which we have explained, is usually clinical straightforward. But the only test we usually have to confirm is like serological test, which is ambiguous in our population, like IgG, IgM, toxo, or CMV retinitis. So this can only, as you have told, add to a case of clinical diagnosis with toxo, because we don't have any other investigation for. That's why we especially took the retinitis cases like toxo and CMV. And also, as you have told, for sure there will be backscattering in active cases. So like we have one more suggestion, is that most of these cases like toxo and CMV will also have healing lesions in most of these cases. Both type of healed and active cases can be seen. So mostly a healing case can be more predictive of these findings than a active case.
But to diagnose and confirm that it is a toxo, it is usually the documentation by laboratory test. They were done in your study?
No, ma'am. That's what I'm telling, that IgM and IgG are, it's not conclusive in our population for a toxo. And this fluid analysis we have not done, which is a drawback.
But when we are suspecting, we usually do this test, and then we can start the treatment, yes. And side by side we usually do this test.
But usually we do serum tests, no? Then only we'll start
yes, sir. But even if it is positive, in some cases, even if toxo is positive, the features are suggestive of more of a retinochoroiditis like
that is correct only, but how many percentage people was negative and you started the treatment?
We have not done toxo, IgG, IgM in all cases, sir. Okay. Only clinical diagnosis was taken. Okay. Thank you, sir.